My name is Prachi Bakarania, and we're very excited today with Dr. Vitale and Amber and Will to present our webinar. Let's jump right in. Today's webinar is going to be on the importance of strong bones, strong kids, why bone health matters more than you think. And we are really excited that we have two great experts in the field, Dr. Ilene Fennoy and Dr. Christen Russo, who's going to be talking today. Before we get started, I did want to run a very quick poll. See if I can pull up the poll now on what you wish the next couple webinars to be about. So we have four options. Think it through. If you're able to vote, that would be really helpful for us. If you would like the topics to be on advanced case studies, because I know many of you practice independently, it'd be nice just to brainstorm together. If you'd like it on mental health, low back pain, talking about the sagittal plane, transverse plane, frontal plane sort of thing in adults with scoliosis. Or lastly, if you'd like an orthotics talk from maybe invite some of the top brace makers. In this webinar, we're gonna talk about the normal and abnormal pathogenesis of bone growth, how bone health is impacted in childhood and beyond, the role of lab testing, how radiological testing plays a part in diagnosis and intervention decisions, and then the benefits and contraindications of supplements. I hope everyone's really excited. I know I am to learn a lot.
And before we launch into what I know will be a great session, I just want to take a second to thank Prachi and Amber and Stephanie and our team, as well as our faculty, Kristen and Ilene, for creating, this very rich, ongoing content around best-in-class treatment for children in the space of conservative scoliosis. It's been really fun being able to get together with everyone every 6 weeks or so and learning so much from experts like this. And once again, Prachi and Amber, thank you so much.
Thank you, Dr. Vitale, for giving us a podium to do this. So we couldn't do it without your support. Okay, I'm going to pass on the baton to Dr. Russo.
Good morning, everyone. Let me make sure that I get the correct PowerPoint open so you don't see how crazy my desktop actually is. Okay. So thank you again for the introductions, Prachi and Dr. Vitale. We'll kind of get right into it because we have a lot to cover. I do have some disclosures. I'm a member of the Bone Health Study Group for the Pediatric Orthopedic Society, and I also am a recipient of a microgrant doing some work in this area as well. And Dr. Fennoy has nothing to disclose. So just to go through really quickly the normal pediatric bone growth, and this is definitely stuff that you've heard before, but I think if you don't lay a good groundwork, it's hard to then talk about the nitty-gritty of it. So there's several components of bone, periosteum on the outside, which is more rich and robust the younger that you are. And then there's cortical and trabecular bone beneath that. And then, of course, in the middle of all of our bones is bone marrow, where all of our blood cells are made. And it's particularly in long bones, they have a very specific anatomy. There is a shaft that is a diaphysis that you can see in this picture. And then it becomes broader, what we call the metaphysis. And then the articular surface is where the epiphysis lies. And so between the epiphysis and the metaphysis is where you get that physeal plate, the physis, which we'll be talking about a bunch during this talk. So particularly, I'm going to talk about postnatal bone growth because this talk is not really geared to problems that occur prenatally or in utero. So we have primary and secondary ossification centers for our bones. The primary centers are usually located somewhere in the center of the bone, and the region is cartilage to begin with, and then there's a capillary invasion where the chondroblast, the cartilage there, gets replaced by osteoblasts, and these become our primary centers of ossification. And then we have secondary centers. Sometimes they're at both the proximal and distal ends of our bones. Some of our finger and toe bones are a little bit different. But in the same way that primary ossification occurs, the secondary ossification occurs again. You get this vascular evasion. The chondroblasts become osteoblasts. And the appearance of that secondary center, that epiphysis, is what allows you to be able to see the physis. So the physis is always there. It just only becomes visualized on X-ray once you have that secondary ossification center there that you're looking at. And so we use that secondary ossification center and how it matures for lots of calculations for skeletal age or bone age that you may have encountered during your practice. So I like to think of the physis as organized chaos. This is kind of the questions that we always hated to get during exams. And there's several zones of the growth plate. So there's a resting zone, just kind of the cells are hanging out. And then the proliferative zone is where they are going to multiply. When you have achondroplasia and other diseases like that, this is the zone that is affected. Your hypertrophic zone is obviously where then those cells that have multiplied get bigger. And this is the zone where things like SCFE come into play. There's more of a widening of this hypertrophic zone, and so you get pathology there. And then your zone of provisional calcification is basically right before that cartilage is going to become bone. But so it's kind of organized in a somewhat chaotic way, and this, goes on all throughout your pediatric life. So to switch away from the anatomy and kind of physiology to just bone health and what we'll be talking about more today, there's modifiable and non-modifiable factors that influence bone health. And so your non-modifiable ones are obviously the things that you're born with, your genetics, your gender, and sometimes your ethnicity. And the modifiable ones are the ones that every day you could be doing something different. Could you be eating differently, exercising differently? Are you obese? And then broken up bone has a lot of different components to it. And so I like to think of it as a recipe when you're building bone, not just a single supplement. So the main building blocks, calcium and vitamin D, which we'll talk about today. Without having vitamin D, you can't absorb the calcium that you need, either from your gut or from your bones to get the calcium that is used. So those are the primary ones we'll be speaking about. And then the rest of them on this page, they come in and out of flux about what's kind of popular and who thinks that one is more important. But we're not going to focus on the other ones too much today. So just to go over the biochemistry behind vitamin D. So it's a steroid hormone, and it's inactivated as 7-DHC, and it's activated by UVB rays. So thankfully, these UVB rays are not blocked by SPF, so the dermatologist will be happy as well. You can continue putting your sunscreen on and still get your vitamin D activated. And so once it becomes activated, it then needs to be hydroxylated, not once, but twice, so in the liver and the kidney. And so you have to think about if you're having problems with either the liver or the kidney, or you're taking medications that affect the liver and the kidney, you could have problems hydroxylating your vitamin D that you're getting from within your body. The supplementation then that we give, if you are having problems with that or you're just not getting enough sun exposure, is either vitamin D3 or D2. So D3 has increased availability. You want to take that. That's the cholecalciferol. A lot of times when you prescribe it, I find the formulary at my hospital is pushing you towards D2. It probably is cheaper, but D2 is not absorbed as well. But something also to keep in mind is D2 is vegan or vegetarian friendly because D3 comes from animal fat sources and D2 does not. I'm going to let Dr. Fennoy take over for a couple of slides now.
The other aspects, thank you, Dr. Russo, and welcome everybody. The more specific aspect of bone formation at the cellular level is that we basically have three cell types: osteoblasts, which are responsible for new bone formation, and they make the non-mineralized bone, which are the bone proteins, or also referred to as bone matrix. You have osteocytes, which provide nutrients to the bone proteins, and you have osteoclasts, which are responsible for breaking down or resorbing mineralized bones. The whole bone formation process is two different processes. One, bone modeling, which occurs with growth, and bone remodeling, which is targeted towards maintenance of bone. Next slide. Yeah. Yes. Now, what's important in bone remodeling, which is what is primary activity of bone during adult life, but which is also ongoing in childhood when you have both growth and bone maintenance, is that you have to get a balance between bone formation and bone resorption to have effective remodeling. If you have an imbalance, you get pathology. So excessive bone formation, which means excessive activity of osteoblasts, compared to bone resorption, will lead to increased bone formation and osteopetrosis here on the bottom. I'm sorry, here in the middle. If you have excessive osteoclastic activity with decreased osteoblastic activity, you will get osteoporosis and increases your susceptibility to fractures. Next slide. Yeah. The bone matrix is made up of two types of protein, the fibers of type 1 collagen. It's composed of two alpha 1 chains and one alpha 2 chain in repeating triplets of amino acids with high glycine and lysine. And it's layered in varied orientations, and it makes up 90% of bone protein. The non-collagen proteins represent only 10% of bone protein, and they direct the formation of fibers, they enhance mineralization, they strengthen the attachment between cells and the matrix, and they provide signals for bone remodeling. Next. There are many effects on bone, as Dr. Russo has mentioned, and many of these are hormonal. Vitamin D is often considered a hormone because it's made in the skin, circulates in the blood, and has its action someplace else. The active form of vitamin D is made in the kidney and has its effect on the gut. So vitamin D is one. It's absolutely necessary for calcium and phosphorus absorption that leads to mineralization. Glucocorticoids, however, inhibit bone formation, while insulin stimulates protein synthesis, particularly collagen, and is necessary for normal bone growth. Growth hormone increases cartilage growth and bone remodeling, and is necessary for increased linear growth. On the other side, hormones that affect resorption primarily, parathyroid hormones stimulate bone resorption or bone breakdown. Thyroid hormone stimulates the same, and it's also necessary for maturation. Calcitonin, which is a hormone from the thyroid gland, actually inhibits bone resorption. And sex hormones in the deficient situation stimulate breakdown of bone. But in a normal situation, they're necessary for pubertal growth, and estrogen is necessary for the changes in the epiphyses that result in bone fusion and cessation of height growth. Next. There are other factors like cytokines, which are the small proteins involved in cellular communication and regulation of the immune system. They're major players in autoimmune disorders. And dependent on which of the cytokines we're talking about, they may increase bone resorption or inhibit bone resorption. And then of particular importance are physical factors. Weight bearing and exercise are absolutely critical. Muscle action against bone is an important factor in bone remodeling and stability and strength. Next.
I think we're going to switch gears a little bit, or just fine tune a little bit more about how we assess bone health. I think you can start, Dr. Fennoy.
So there are a variety of ways we assess bone health, both radiographically, using DEXA or dual energy X-ray absorptiometry, This is recognized as the reference standard for assessing bone mineral density in children and adults. X-rays can be useful, but they require 30 to 40% loss of bone to identify any deficit. So they're not primary methods for evaluating bones radiographically in terms of bone strength. Quantitative ultrasound is used in adults, and quantitative computer tomography or high resolution peripheral quantitative computer tomography have been used to assess bone strength in both adults and children, but they're primarily research tools and not used routinely because of their high radiation exposure. And then MRI can also be used for bone strength. In terms of bone turnover markers, we have C-telopeptide, which is a marker of bone resorption, and osteocalcin and procollagen type 1 N-terminal propeptide, both of which are markers of bone formation. In terms of bone health markers, primary ones are parathyroid hormone, calcium, magnesium, phosphorus, and alkaline phosphatase. They give us major information about the activity of bone.
So I'm just going to just start a little bit with what laboratory studies we might order. So I like to think of like a bare bones if for some of my non-unions, or if I'm taking care of patients with scoliosis, I usually just start with something very simple with calcium and vitamin D. And if I'm thinking about any of these first or especially second tier labs, I probably need somebody like Dr. Fennoy on the team at that point because I don't know how to interpret and then treat all of these labs together. But this just kind of complements what Dr. Fennoy already said, that you can use the relationship between a lot of these labs in order to start your investigation if you are worried or concerned that there might be bone pathology going on. And then we'll go a little bit more into imaging for bone health. So like Dr. Fennoy said, you really can't use x-rays to determine bone quantity. But our radiologists love to give this read. It always says disuse osteopenia, which makes parents really just crazy and me crazy as well. But we really need to use DEXA for this. But unfortunately, in our pediatric population, it's not always a great test to order. So just a little bit more about why, x-rays and what they're really showing and what disuse atrophy or disuse osteopenia is. So as mentioned before, we know that you need both gravity, this external force, and also the muscle contractions, your internal forces, in order for bone health to be maintained. And so we know from when we unload a limb, like in a spinal cord patient, or even if we're just immobilizing for a fracture or something like that, we see both bone catabolism and muscle atrophy. So the muscle atrophy that you see in a patient with a spinal cord injury is because of that stimuli that's not happening to the bone. And in those patients who are mobilized, you can see a decrease in thigh mass in as little as 4 days. So it's a lot. It's something that you definitely need to prepare patients for and then make them understand that it's both the weight bearing and also getting their muscle back that's going to get their bones back to health. So Dr. Fennoy will talk about this a little bit more, but just to go over kind of the basics of a DEXA, which I'm sure everyone is kind of familiar with from for older people. So it's basically low energy x-rays. And so they're absorbed by the bone, and whatever's not absorbed on the other side of the body is measured. And so the denser your bone, the more energy it absorbs. And so it spits out this score. So your T-score is compared the energy that is absorbed compared to a 30-year-old of the same sex, but your Z-score is individualized for your same sex and age. So basically, we're only using the Z-score in pediatric patients. The problem occurs is if you don't have a good sample size, you can't get a great Z-score. So I often see patients in the office that have come in, they have outside studies from these like very tiny radiology places that are doing DEXA scans on these pediatric patients, and they have absolutely zero way to interpret them. And it's really frustrating. I don't know, and I defer to Dr. Fennoy about this, if we even have a large enough population at Choney to be able to do this. But I think without having a large tertiary children's hospital, it's really hard to get this data.
Just in following up on that, on the Z-scores, there are two major types of DEXA machines, one made by Hologic and one made by GE, both of which have databases for pediatric populations. So one of the things that is supposed to occur on any report is identification of the machine used. And that's where you can get reasonable, not perfect, but reasonable Z-score data, because it's using population-based data that the companies have generated, that particularly for Hologic, that is national in origin. And from that data that was generated from the bone mineral in childhood study, of which Columbia was a part and represented 5 institutions that included multiple racial groups, from 5 to 18 years of age, it was determined that there were changes in bone mass throughout the pediatric age group. You can see the graph here with females increasing up to about age 25, and men the same, and then stabilizing throughout the young adult age. And it's this group, the stable group, from which the T-score is generated, and then declining thereafter. So this is normal change in bone mass that occurs with age. Next slide. The further studies from the bone mineral density study in childhood have demonstrated that when you follow children over time, their bone mineral density decreases in puberty, but if you adjust for their height, okay, it's pretty stable. So this has led to the statement that for pediatrics, bone mineral density reports or bone mineral content reports need to be adjusted for height. And so when you get just a measure without a height adjustment, that's a problem. In general, most centers do not do height adjustments unless the referring doctor has specifically asked for it, and even then they may not do it. Only tertiary pediatric bone places tend to perform this adjustment. Next. The other feature that is a major feature of childhood is that if you have a low bone density, okay, you tend to track in childhood, you tend to track with that same bone density over your lifespan. Now, these were patients who were followed over 6 years, and they were followed to understand whether there was a genetic tendency for low bone density that differed from the age-appropriate changes or the height-adjusted changes. And they compared these children into groups where their bone density was low, here at the bottom, in the normal range, according to Z-score, or high. And they looked at it in the unadjusted versus adjusted for height. And children who began with a low bone density, though they improved over the 6 years, never came up into the normal range. Children who began with an average stayed in the average, and children who began with a high stayed in the high group, even though they did come down a bit. And it didn't matter whether you adjusted for height or not. So that it's very important in childhood to maximize where you are in terms of bone density, to not ignore deficits that may occur from lack of exercise for medical reasons or otherwise, lack of weight bearing, because you need to have the best bone density you can have during childhood. Next. So this is a similar rating that shows the subjects divided by their bone density scores. Next. So we find that bone increases in mass throughout childhood. A peak bone mass is not reached till late teens or early adults. So you have opportunities to do better throughout childhood. Failure to reach peak bone mass results in earlier loss of bone, which is associated with aging. So if you're higher in bone mass in childhood and you reach bone mass at a maximum, as you come down, since everybody's going to decrease after age 30 to 40, you will remain at a higher point than if you were low to begin with. Bone densitometry is only part of the comprehensive skeletal screen. We've talked about the hormones, other factors, weight bearing, exercise, all of which are crucial. And for pediatric patients, we tend to look at spine and total body less head as the DEXA results that we want, because the joints, hip in particular, are changing shape as children grow and therefore are not as reliable in childhood as they are in adults. So we don't want to do a DEXA that is comparable to the adult. We want to do an DEXA that gives us the maximal information for the pediatric patient whose bones are in constant change. Next slide. Now, in terms of how we define disorders of bone, the primary disorder that we refer to is osteoporosis. There are other terms, but osteoporosis is what is most common in the general population. And it represents a disorder of bone strength, which predisposes to an increased risk of fracture. You can expect that with osteoporosis, you have decreased mineralization, but that can be the result of congenital disorders, acquired conditions, like vitamin D deficient rickets. It can be the result of medications like glucocorticoids. It can be the result of dietary or nutritional disorders. We have seen many autistic children who don't have any calcium in their diets and therefore have osteoporosis. And it can be the result of physical behaviors like lack of exercise or weight bearing, particularly weight bearing problems we see with patients with neurological disorders. In whatever case, it results in increased fractures. What we use as a definition of osteoporosis in pediatrics is either the presence of vertebral fractures that occur with low trauma, like falling from a standing position. This is rare in pediatrics, but it does occur, and it suggests bone fragility. Or we use the low bone density from a bone mineral density study with multiple long bone fractures. So either will make the diagnosis of osteoporosis in the pediatric population. Next.
And so I think before, hopefully we're getting to osteoporosis, but we're getting low vitamin D first. And so it's a crisis. 70% of children in the US are estimated to have a low vitamin D. And so about 60% of them are below 30 and 10% of them are severely deficient below 15. I feel like whenever I test them in my practice, they're definitely below 30 and a lot of them are in the teens and the lower numbers. And it can cause a variety of problems. And sometimes it's not always so obvious what it's doing. You're not having these osteoporotic, thank God, these osteoporotic fractures yet. And it's presenting in different ways. So I think we're going to talk a little bit about that moving forward and then specifically kind of how we treat it.
So when we treat bone disorders, the first thing to do because vitamin D and calcium are so important to bone health, is to look for these primary deficits. We can also have deficits in phosphorus. They're much less they're much less likely than deficits in calcium or vitamin D, but there are conditions that predispose to it, and you will see osteoporosis in patients who have major deficits in phosphorus. So our primary way of dealing is to screen for these kinds of disorders and treat them before anything else, and reevaluate after we have corrected these disorders. In addition, we focus on weight and physical activity deficits. Weight can be an issue. There are those who are very low weight for height. Protein intake may be decreased. Attention, therefore, has to be addressed to diet. That will also include intake of calcium, phosphorus, vitamin D, all of which need to be ensured to be adequate. And finally, exercise, particularly weight-bearing exercise. In children who have compromised physical activity, physical therapy can be crucial in improving the ability to use muscles and to weight bear. We push the individual to do what they can do. And physical therapy can help target what is doable for a given clinical diagnosis and ability. And finally, the adequate protein intake. Protein stimulates muscle, and muscle activity against bone stimulates bones. Medications are specifically targeted to individuals. Medications specific for low bone density are targeted to bisphosphonates in the pediatric age group. They are state-of-the-art therapy for children. They are not FDA approved for the pediatric age group, but there are no FDA approved medications specifically targeted to deal with low bone density in the pediatric group. Nevertheless, this is a therapy we have, and it's been well demonstrated to work across multiple different diagnoses for children with low bone densities and increased fractures. We tend to limit bisphosphonates. Could you go back one slide? I'm sorry. We tend to limit bisphosphonates to children who have vertebral fractures or low bone density plus multiple long bone fractures. So it is not state of the art for simply a low bone mineral density. Next. Just to go over what's thought to be the appropriate vitamin D and calcium supplementation. The RDA, or the recommended dietary allowance, is here listed from age 1 through age 30 for calcium on the left. And then the upper limit that's safe for an individual to take per day is listed in the next column. And then the last two columns are vitamin D for the same two characteristics. I listed infants at the bottom. There are no recommended dietary allowances for infants. It has not been well studied enough. So we use what's considered adequate intake, which is what seems to be appropriate from the data that we have for the pediatric infant, as well as showing you here the upper limits. The big thing here is there is a lower limit and an upper limit, and we need to be mindful that it's not just more is better. Next. To give you an idea, we've talked a lot about the lower limit, hypovitaminosis D, and its contribution to osteoporosis. But what happens if you get too much calcium in your blood? Hypercalcemia is a serious medical condition, and it may present asymptomatically, particularly for those with low serum calcium levels, 10.5 to 12 in the total serum calcium in terms of milligrams per deciliter, or ionized 1.4 to 2 milligrams per deciliter. As you rise, symptoms tend to develop. Severe hypercalcemia is defined as a total calcium greater than or equal to 14, or an ionized calcium greater than or equal to 10 milligrams per deciliter. In that case, patients can present with nausea, vomiting, dehydration, confusion, go on to somnolence, and coma. People with moderate elevations between 12 and 14 may have polyuria, polydipsia, constipation, fatigue, muscle weakness. They may have minimal symptoms. Only with severe do you have clear, unequivocal symptoms. With mild and moderate, it may be very hard to recognize that the patient has anything adverse going on. If you do laboratory studies or testing situations, you'll find that patients with hypercalcemia may complain of inability to concentrate. They may go on, if it's long enough, to have calcium in their kidneys or nephrocalcinosis, which can lead to kidney failure. They may demonstrate an abnormal EKG and arrhythmias. Usually the arrhythmia is one of a slow heart rate or bradycardia. Protein supplements are another way that patients can go overboard in their attempts to have a healthy diet. They are available as powders, shakes, and protein bars. Different proteins have different effects. So whey proteins have been shown to improve systolic blood pressure, whereas soy proteins lower both systolic and diastolic blood pressure. Soy protein affects lipid levels. It may increase LDL cholesterol and triglyceride, which are beneficial to improve heart health. Overall, protein increases muscle mass and linear growth. So it is definitely an important dietary content issue, but overboard can have effects. You get increased urine calcium excretion, and it is well known that patients with hypercalciuria, excess urinary calcium on a chronic basis, get osteoporosis. So too much protein is not going to help the situation. Excess protein increases the fluid filtration of the kidney, and that ultimately leads to chronic kidney disease. Again, excess protein is not what you're attempting to get. Protein, like calcium and vitamin D, can be too much or too little, and one needs to use care and how you administer it, work with dietitians, make sure you're not overdoing it or underdoing it. Next.
So kind of piggybacking off of what we're telling patients about what supplements they should be taking, I wanted to investigate this a little bit further. So a couple of years ago, I got a microgrant to look at the kind of caregiver comprehension of what we're telling patients. And so we're all busy. We're all seeing too many patients a day, and we don't really have time to counsel them and everything. And if there's pediatricians on this call, it's how do you fit this aspect, bone health in, if, there's other pressing things going on. And so I've taken it upon myself to kind of have this conversation as much as possible with my own patients. But I wanted to figure out what they were hearing or what they knew, just so we had a baseline. So we distributed this survey to patients in my office and also to my partners up at Columbia for all new patients. And you can see the survey questions on the right. And so what we found out was that there were deficits in caregiver knowledge about calcium and vitamin D kind of across the board, but especially in the Hispanic Latino community. Again, this may be a little bit biased because we do have a large Hispanic Latino population in Washington Heights. But that was what we found from this study. And we also found that there was a desire to learn more about vitamin D and calcium. And that even if their parents or caregivers were having discussions with physicians, it wasn't really having an impact, obviously, if there were deficits in caregiver knowledge. So lots of people answered that yes, they were having discussions with their pediatricians, but it wasn't sinking in. And so from this, I tried to create targeted infographics to create memorable conversations with the caregivers and just have the consistent information be given again and again so that I can do my part. So we created this magnet on the left, which has a lot of the values that Dr. Fennoy went over with in the other slide about how much, at least the minimums you need of vitamin D and calcium per day, and just to get an idea of some of the foods that are rich in both of these sources. And then I always talk about sunlight because lots of people do think or they're aware that you get vitamin D from the sun, but it's kind of like this Olaf phenomenon of how much vitamin D you're actually getting from the sun. So you need 30 minutes of exposure 5 days a week with all four extremities exposed in order to get enough vitamin D from the sun. And that's unlikely to be happening most of the months in New York City. And so, especially during the winter months, I think that everyone should be supplementing. But sometimes, even during the summer months, this doesn't happen. And again, sometimes in these super healthy athletes that are spending so much time inside, the gymnasts and hockey players that are, kind of never seeing the light of day, this is super important for them to supplement. And I created this supplement list that you can see on the right. So these are all available from Amazon, which these days maybe is not a great thing, but at least parents know where they can get them. They're all what I call child friendly. So they're chewables or gummies or real chocolate. And this just helps, I think, parents, they can leave with physical materials. They know where to go and get the stuff that they need. And I also printed it out on a half page so then I can write stuff on the other side. And at least parents have a starting point for where they can be going from this. So just to end, I'm going to talk about two topics where we're still doing a lot of work with hypervitaminosis D and these areas. But so because this is a spine lunch and learn, talk a little bit about AIS. And this is like a little bit of a chicken and egg phenomenon. We don't really know which one comes first, but we obviously know that when you're vitamin D deficient or you have lower bone density, you're going to have poor postural control, which can affect AIS development. And then also at the same time, we've been talking about if you're not going to have great osteoblast proliferation, this can also affect your AIS development and progression. So there also is some talk about if there's a genetic link, if there is a vitamin D receptor polymorphism going on where you're actually resistant to the vitamin D that you're taking, and is this somehow helping you to develop AIS? So things that we do know is that vitamin D is correlated obviously with calcium levels, and it's correlated negatively with Cobb's angle. So we want to be seeing the opposite there. And we'll show a graph later on of somebody who looked at this. So if you already are an AIS patient and you are vitamin D deficient, then you're more likely to have surgery when you're younger, and you're more likely to report lower scores on the function test, self-image test, and the SRS-30 in the post-operative arena. And we really need to do further work to see if vitamin D supplementation alters curve progression or can stop it from getting worse and improve patient outcomes. But so there are a couple of studies that have been done, and this looked at postmenarchal girls, so it's not our typical patients with AIS, but you can see here more AIS patients had vitamin Ds less than 20, and as you did not have AIS, your vitamin D was increased more to that normal, or at least borderline normal range. So we are seeing in our AIS patients that they are having low vitamin D, and again, really hard to tell if what the chicken egg phenomenon here, what is happening first. And so this study looked at two groups, and there were small groups, about 25 in each group. And one just got standard treatment for AIS, no supplements. And the second group got vitamin D, calcium, and melatonin. I'm not really sure about why with the melatonin. But you can see that the Cobb angle after 1 year definitely was decreased in this group that had gotten the supplementation, as opposed to the group that got no supplementation, the Cobb angle actually increased. So the last thing is red S. So in the past, we used to call this the female athlete triad. When we stopped doing that, because this doesn't just happen in females, and it's kind of been expanded to include a lot of other areas that is not just the female athlete triad. But this includes kind of a broad definition of impaired physiologic function. Could be metabolic, could be menstrual, could be bone health, could be cardiovascular as well. And these are the patients that, they're coming in, they're doing everything. We're not sure if they're getting the proper nutrition. And you start to ask more questions, and you kind of end up with all of these different aspects going on here. So the old female athlete triad is that triangle that you see here. And now it's been expanded to include all of these other areas. And you really need to have, multidisciplinary approach to have all kind of members of the team on board here, because this can be, very controversial, even convincing parents that this is going on. But basically, it's your relative energy deficiency, and it's usually kids that are in sport, and you really need to have nutritionists on board for sure. And then kind of leading back, to where we started with all of this and how this usually presents to us in terms of bone health is that these are the kids that you're seeing with stress fractures. And so we really need to try to get on top of the red S before it becomes to this point. So I'll let Dr. Fennoy just kind of sum it up, and then I think we'll be ready for questions.
Yes. To understand, diet and activity, particularly weight bearing, are important contributors to healthy bone. Both deficiencies and excess of key nutrients may impact bone as well as overall health. Children in particular are increasing bone throughout childhood to reach a peak bone mass and in their mid-20s to 30 years of age. Failing to reach that peak ensures reaching a low bone density associated with increased bone fragility at a younger adult age. So we want to avoid that. In pediatrics, bisphosphonates are the only medications targeted specifically at bone strength. They're used in the setting of vertebral fractures or low bone density with multiple fractures or significant bone pain in disorders of low bone density. That latter group we didn't talk very much about, but includes transplant patients sometimes. It's a variety of different disorders, including fibrous dysplasia, but associated with significant bone pain. So bisphosphonates have a limited use, whereas diet, activity, protein, calcium, phosphorus, magnesium are all, and vitamin D are all crucial. And you're always balancing not too much and not too little. Thank you.
Thank you so much, Dr. Fennoy and Dr. Russo. We have a few questions. We're hoping maybe you can talk a little bit about. A lot of our patients are post-fusion. They have hardware in their spines. What is the typical way that you would measure bone density in this patient population, especially if you're worried about hardware failure?
We measure bone density at sites not involved with the hardware. So there have been data recently generated to get appropriate bone density at the distal forearm. Okay. When we can do distal femur, and we can do the hip, the more the child is an adolescent and the closer to the end of puberty, the more the hip looks like the adult and is not going to be such a problem. So we can use other sites. There is reference data available, but again, this requires a center that specializes in children and can give you the norms for those areas, or the reader has to be one with access to the reference ranges for that equipment.
Thank you so much. Another option someone asked is if cod liver oil is an acceptable vitamin D supplement source versus a synthetic vitamin D supplement?
I don't think cod liver oil is used just because of the side effects that come along with it. It's usually other like fish oil that we use. I think some of it may include it. And with kids, you can use any adult stuff, but just the pills are usually big, and sometimes the kids won't tolerate it.
It's available. It's not as well quantified as to the amount you're giving. So you can be at greater risk for giving an overdose. So it's not the preferred, but I have had patients who wanted to use it and did use it. And it's certainly at the beginning of the Industrial Revolution, when it was first realized that vitamin D deficiency was the issue causing it, cod liver oil was the treatment of choice. The other issue with cod liver oil is it has vitamin A in it, so you can wind up with excessive vitamin A if your only deficit is vitamin D.
Thank you both. That was an amazing overview of a complex space and gives me a much better understanding of where we are. So if you distill it all down, right now, every patient who has a curve large enough to require either bracing or scoliosis-specific physical therapy is also recommended 800 units of vitamin D with calcium supplementation. Can you sort of give me your opinion about whether that's appropriate, either based on evidence or opinion? That recommendation came out of one or two studies, and as Dr. Russo pointed out, it's been hard to replicate some of that work, looking at the particular relationship between vitamin D calcium supplementation and scoliosis curve progression in adolescent kids. What are your thoughts?
I think you could argue that people should be taking that supplementation regardless, right? That anybody that walks through your door that is boy, girl, especially, if you are a girl, though, you should be taking that as the recommended daily allowance. So it's some of these studies, it could apply to almost anything. So I don't think there's definitely any harm in doing it. The question really is, are we doing something by suggesting it?
The other issue to recognize is that if a person is taking the recommended dietary allowance, they're taking a value that's appropriate for 97% of the population. So it's unlikely that you're going to overdo it. Okay. So I don't think there's any problem with the recommendation of taking the recommended dietary allowances of calcium and vitamin D. But what you do have to do is get some history about diet, whether they have an unusual diet. The biggest problem we're seeing with patients are patients who are autistic or have restrictive eating disorders. Those patients need to be identified and specifically referred to nutritionists to get the right amounts, because their restrictions are what's causing the problems. And you don't have a good way of figuring out which things they have decided to restrict.
Yeah. And what about with protein? I was interested in the very positive, more holistic effects, scoliosis aside, of soy protein. Should we all be taking soy protein supplementation given the equally unlikely possibility of overdosing?
I think if you have a varied diet, it's good. You don't really need to switch to soy over cow's milk or oat proteins. There's been a lot of push to switch to altered protein milks to avoid the saturated fat that's in cow's milk. But cow's milk can come in low fat versions, and you still have all the proteins in there. Cow's milk is whey and casein, so you're getting some of the whey benefits. So people don't have to totally switch. In some individuals, soy is not the best choice. Patients with thyroid disease, soy inhibits the absorption of thyroid hormone. So if you have to take thyroid hormone every day, you may not want to be giving a soy protein, because you're interfering with the absorption. So it has to be a little bit more individualized, but again, it represents how much you're doing and how much of your diet that represents.
We have some good questions from Marissa Muccio, our friend, about hypermobility. Christen, you want to take that on?
Yeah, I mean, I think that there really, honestly, there's not a lot of studies going on at all. So when we're looking at these specific smaller populations, something with hypermobility, like you mean from like having like a high Baton score or something like that. Yeah, it is. It's really difficult because we don't have the numbers to study it on a whole. So I think in terms of like collagen supplementation, is that what you're referring to here? I don't know that we honestly have a lot of that information, so I couldn't give it to you. I don't know if there's anything kind of ongoing now with that.
Hopefully, to wrap up the questions, I guess just a way of empowerment. What if you are the kid that did not do any sport, that sat in the corner, that had horrible posture, and now as an adult, you are just trying to get healthier? Is there hope? Is there hope for us? Is there hope for the PT that has this patient in front of them that we can build muscle mass, we can improve bone density? Anything you can sort of impart on all of us?
Yeah, I mean, I think also to answer the question about are we prescribing PT, I mean, man, I wish I could prescribe PT for these patients, and I wish there were enough pediatric physical therapists that could do it. But I think the answer, especially in New York City, is no. And I always ask what the kids are doing. It's often one spectrum to the other, right? Either the kids are playing 8 days a week or they're playing -2 days a week. So there has to be some kind of in between there. I think the loss of the kind of recreational youth sports is terrible. And we're seeing a rise in, obesity, and in low bone mineral density because of that, because of this kind of all or nothing phenomenon there. So I would love to bring back recreational sports that aren't so competitive and maybe keep our kids healthier.
Yeah, we certainly have been encouraging more often that children use stairs in their building and walk up and down stairs, that they use YouTube exercise videos to do some resistance exercise, stationary bikes. Many buildings have a rec room with stationary bikes, encouraging them to use those and increase the amount of time that they're using them. It doesn't require major expense for many of the resistance exercises that are appropriate. But the more the child is compromised in their basic musculoskeletal functions, the more they need physical therapy to get those exercises correct. The more it's just a sedentary individual, things like planks, things like sitting wall exercise, where you're just leaning back against the wall and sitting and in a sitting stance, holding on to another for as long as you can, and repetitive 2 or 3 times a week, and increasing your time. All of these kinds of exercises are extremely valuable for people to do if they have a sedentary life, to maximize their bone health.
Yeah, we couldn't agree more. And my team is laughing a little bit because we're always pushing the value of isometric core strengthening to our patients. Well, that was a great overview of a very complex area. Thank you for making it so comprehensible and so fun. Once again, I appreciate everyone joining us on our ongoing quest to do better in this space. Our next lunchtime learning series will be, well, before we get to that, we have an opportunity to get together live at our annual symposium on the pediatric spine. This is our 11th annual event. It's going to be held here at Columbia University Medical Center on Thursday, June 26th. We already have great registration, so please join us. Once again, Prachi and Amber have put together an all-star faculty and a really exciting day for us. So look forward to seeing you all there. I also am reminded that our 10th annual Summit for Safety in Spine Surgery, which we founded is coming up quickly. It's at the end of May. This is also a great event to meet colleagues and talk about ways that we can make spine surgery safer together. So hope to see some of you there at that event. With that, I will, 12:30 again, wrap up. Thank you to Dr. Fennoy and Dr. Russo for your wisdom and expertise here. And thank you for all the rest on the call for helping to drive this important series. Appreciate everyone taking time to join us on this Monday afternoon. Thank you very much, everybody.
Thank you very much.